and stuff.
Yep.
Let's see.
So I will admit people in.
Okay, cool. It's over.
I don't want to spoil it for you if you haven't watched it.
Good morning, everyone.
Good morning.
Good morning.
We'll just give a minute or two to get everyone some time to join. But thank you all for coming this morning.
Yeah, thanks. Hi, Pamela. Hey, everybody.
Hi, I'm not sure if my mic is on. Is it on?
My mic, yes. Your mic is on also.
Oh, okay. Hi, thank you.
No, it doesn't look like it's there.
Okay. Hey, Bree, your microphone is on. I don't know if you want that on.
Oh. Okay, I had it on. What happened? Start by.
All right, so we've got Karen and Pamela. We've got Jackie Jacobson. She is the Vice President of Operations. We've got Janelle as a guest, Chris as a guest, lots of fun people as a guest. I don't know if everybody wants to introduce themselves.
Sure, I'm Pamela Walcher. I'm just starting with Accurate. I'm in the orientation process. Hi.
I know.
Hello,
Hello.
nice to have you.
Thank you.
Jenny, do you want to introduce yourself? Or should we just get into it?
We should probably just get going for
Okay.
time. But my name is Jenny. I'm the Director of Clinical Services here.
All right, so this is a demonstration on how to use the electronic charting. Once you use the code to get into your iPad, you are going to see this screen to log in, and you all should will get, if you don't yet, a username and a password. You do have to spell out accuratehomecare.com and use your password, and you will log in. I usually tell people to press enter on their computer and not on the screen. It seems to work a little bit better, but not everybody. This here is an office communication. If someone is trying to get a hold of you to let you know that there's a correction on your electronic charting, it's going to be here, and you would click on it, and we'll go over this more towards the end. It'll make more sense, but you click on it and there'll be a note from your clinical manager saying what needs to be done, and then you can go in and do it. So from here, you would go to client and then client list, and you would click on it, and just your clients will show up. But if you have more than one client, you want to make sure that there isn't anyone sitting next to you as those clients are shown. And then you pick the correct client, and then you are going to go to schedules. There's a schedules up here. I call that the white schedules, but this one is going to be blue, as you can see, blue. This is the POC is a plan of care, and that has everything on it there. We're not really going to do anything with that there, but it's just an FYI. It has, my notes from the last visit, etc.
Hey, Allie.
Uh-huh.
Sorry to interrupt. Will you just show them what page shows up when they first get into their client name? It goes on that profile tab
Oh,
in the
sure.
blue. Yeah. This is what you'll see once you click your client's name and
Mhm.
get into their chart. You'll see their profile page. That's the first tab you land on.
Yep. Profile page, and then you would go to this blue schedules here. Thanks, Becky. Blue schedules, and you look down for today's date. And oh, I also wanted to say when you go to client and client list, you want to click on your client's name, not the box that's next to it. So we're going to go to schedules, and we'll go to today's date, and I'm going to double check that that is my name and that is my shift. And then I'm going to click on eChart. And then what comes up here, this is where we punch in. So this does away with the paper time card. So my shift started at 08:30. I can type that in there. I'm going to say confirm place of service here, and then save and continue. And sometimes something will come up that says maps would like to use your current location. You'll say allow while using apps, because we do use GPS to make sure that you're actually in the home and not at your house, but you're at the client home. So these two boxes, standard precautions observed and patient tolerated session well, those always have to be checked. First,
Allie, can I just stop for 1 sec?
Mhm.
As you'll see, we're in something called a tab called Pediatric SN Visit.
Mhm.
Even if your patient is an adult, this is your head to toe assessment for all your patients. It doesn't matter that it says pediatric skilled nurse visit and we're PDN nurses, private duty. This is what this replaces that paper health status record that you guys use in the home.
Yep, that's right. And you'll go to vital signs, add reading. It'll come up here. You put the time down. You want to put the time down so that it's after your punch in time. So let's say I did punch in at 8:36. I would not want to put 0800 for my time that I did my vitals. So just to be safe, I'm going to put 0845. I did a blood pressure. It was 120 over 80. The site was their left arm, and it was while they were laying down in bed. Okay. Temperature was 97.6. The route was axillary. Respirations we'll put at 18. O2 sat, I'm going to put 98%. If they're on room air, you would just put room air, RA. If they're on O2, then you would put O2. Delivery method would be nasal cannula or a trach, something like that. And then the running rate would be, I'd say 1.5 liters per minute. Pulse, if you listen to their heart, you can put a pulse here, but a lot of us just use the oximeter, and that would be a radial pulse. So let's put the pulse in for 80. And it's regular heartbeat or irregular heartbeat. I'm going to save. Vitals added successfully. Press OK. And then this is where this is your head to toe assessment. It's going to go through all of the body systems. Almost every box here is going to have check marks in it, but only check what is applicable to your client. But we want to try and check as many boxes as we can. So here we've got GI and nutrition. So we'll say the abdomen is soft and non-distended. If we're dealing with constipation, you can do that PRN meds given. And just a note for these comments, you would only want to comment if something was outside of their baseline. If they always get bowel meds or they always have constipation, you maybe don't want to check that every time unless it gets worse. Bowel sounds normal. I do not like that word normal. I prefer baseline or typical, but here we are. We always check if they have a G tube. We're always going to check tube placement. If they are tube fed and their diet is formula, you check diet formula. The G tube site appearance, if it's normal, you just check it. If there's drainage or if the drainage is baseline, you don't have to make a note or even, I would check drainage, but oh no, you don't. Site appearance, and then you're good. G-tube, peg, type, and size. You don't have to put that in every time. That's going to be in your interventions. But if that's what they have, you want to check mark it, and you're just noting that you know what the size is or you know where to find the size if needed.
And you've assessed the area.
Exactly. Bowel sounds all quadrants. If you don't have to always, if you know the last time they had a BM, great, you can put that in there. A lot of times you don't until you do a little bit more investigating, and we'll go through that. Stool, you do not need to put anything here because we will be documenting stools in the intake and output, and I'll show you where that is. The date of last G button changed. If you're working Monday through Friday in the same home, you can just put it down once when the last G-tube was changed. You don't necessarily have to put it in every time. And this is where I tell people you kind of got to be careful because there's boxes on either side. If you want to go down one side, you have to remember to go back up and go down the other side. I choose to go side by side. So for ENT, I'm going to click on ensure airway is patent. Emergency management, I'm going to check because I'm familiar with what the client's emergency action plan is. If there is a sign or symptoms of infection, I would check that and say, yellow nasal drainage or increased coughing or increased secretions. But then you're going to want to fill out an infection form, but we'll go over that later. If there's ear drainage, we click that, color them out. We would want a comment. If there's nasal congestion, you would click that and then we'd want a comment. And then maybe something more in depth. Color consistency, thick yellow, continuing to monitor, a yellow zone protocol initiated, etc. And then down here with CV, cardiovascular, this one should always be filled out. Heart rhythm is hopefully regular. If they're normally irregular, irregular, we all know what that means, right? It means that they're, yeah. And a murmur. If these are not baseline, we'd want to comment. Fluid retention, edema, no. If we have orders to take daily weights or weekly weights, we'd want to put that in here. Peripheral pulses palpable. If they're not palpable, just say, you can put a comment in here one time, not every time, but one time baseline, client unable to palpate lower extremities. Cap refill, we want less than 3 seconds. Modeling, if you are working with a patient that's on hospice and they're nearing end of life, that's when you would be making a note there. Shortness of breath with exertion, we'd want to note if it's yes, but if no, then we'll just say no. And to some point, everybody has shortness of breath upon exertion, but if it's abnormal, again, we'd want to know and have a note taken.
Allie, can I stop you for a minute? I guess I need a clarification on regular, irregular. I know what a regular rhythm is. I know what an irregular rhythm is, but I'm not sure I know what a regular, irregular rhythm is.
Okay, so that's if it's predictable. If it's an irregular rhythm, but it's the same beat, like if it's a bump, ba-dum, bump, bump,
Okay,
bump,
so
ba-dum,
if it's
bump.
like by Gemini or something like that, where they've
Mhm.
been in that for a while. Okay, that
Yep.
helps me. Thank you.
Yeah, sure. Okay, so then we're on skin. We'll always want to have something here. Skin temp, if it's at their baseline, that's great. Signs and symptoms of infection, wound care, wound location, dressing, positioning. If you are either observing them change position or you are changing their position, we want to click that. Hygiene, if we are, even if we're not giving a bath, we are noting that they are clean and they are dry and they don't, they're not dirty. Rash, that's self-explanatory. We always want something for color. Within normal limits, I have one client that's baseline is very, very pale. We would put in normal limits unless she were to get really, really pale. Skin turgor would always, well, hopefully it's good, but you always want to say something about the skin turgor. And then there's skin assessment, dry and warm. And I'm just going over stuff that is what you typically would see with a typical patient. That's not going to be baseline for everyone. And now respiratory, always have something in respiratory. Lung sounds clear. I have a client has always bronchi. That's baseline. You can just put baseline in here or you just leave it like that. Should be good. If you do suctioning on your client, you would go to this. There used to be, a suction sheet. This is replaced by the suction log. You go to the suction log and scroll down. Oh, add new suction log. Here we go. This is the date, time. Let's say it was 08:30. 08:30, and I suctioned. Oops, I suctioned a trach. The color was white. Consistency was thick. Amount was, I would say that within normal limits would be medium, copious would be large, and scant would be small. It doesn't matter how you use these so much as you use them the same every time. So scant is, if you're going to have scant be small, then have it always be small. I'm going to say within normal limits. I'm not going to make any notes because that's typical when they wake up. They have lots of secretions. I'm going to press save. And then let's say 10 minutes later, I have to go in and suction again. You just add new suction log, put in a different time. A lot of questions are going to be, do I have to have the exact second that I am suctioning? No. Let's say they're having a hard time and you're suctioning for 15 minutes at a time. You're doing a cough assist, and then in between the cough assist, you're suctioning. Just give me a ballpark within, 15 minutes, or suction from 8:30 to 8:45. I don't care if it was 8:31 to 8:36 or 8:26. Doesn't matter. Just a relatively educated guess, and then the location, and yes, I know that part. Okay, and then we're going to close. At the end of your shift, you're going to put save and submit. But for right now, we saved it. It's going to save. We're early in our shift, and then we're going to close, and we're
Allie,
back.
that form is one of the ones that only saves. You don't submit it.
Oh,
Oh,
okay.
If they try and submit it, it just doesn't do anything. So it doesn't hurt that you hit that button. Just know
oh,
that
okay.
it just doesn't submit it because it's an ongoing form for
Oh,
tracking.
okay. Sure. Great. Thank you. I wouldn't have known that. Obviously, if they have oxygen, if they're using oxygen, I would put it right here via nasal cannula, right? Frequency, if it's 24/7, you can put that in here. Or I would just put in what for your shift. If your shift is 8 hours, just put 8 hours. And then, typical baseline for patient. We've all known somebody that's been on oxygen, I think, baseline. Care and use of equipment. The equipment that you use, you make sure that you take good care of it. That's basically what I think that means. Cough, if they have a cough, no. If yes, everybody coughs sometimes. But trach size and type, again, you don't have to put that in every time, but I would click it just to know that you know what your client's trach size and type is, or you know where to find that information. Date of last change. You can put this in there if you have that information. Again, you don't have to put it in for every shift. If you're working, 4 days in a row and you're putting, it was 2 months ago, or a month ago, that's fine. If they're on a ventilator, you want to put yes. And then if you have a respiratory flow sheet, that this is what is going to replace that. And it's a ventilator flow sheet. We are gonna, just like with the vitals and the suctioning, we're gonna add new reading. And you would fill out the information that is applicable to your client, and that is going to be on your interventions. But these are readings that you probably have memorized or know very well, and you can write them down from you can write them down from, or double check them with the vent and then write them here. You would add those. Let's say we checked it at 08:35. And if it's an ST mode, volume is 480, rate is 14. And then we're gonna just fill that. I'm just gonna add it just so that you can see new reading and okay. And then
Allie,
we're
I'm
gonna,
gonna interrupt you for 1 second here.
Mhm.
When they go to add a reading, the vent settings should show up.
Oh, really?
Yes, it's
Wonderful.
just not set up for this patient. So they will show up. They'll be like in parentheses next to each setting.
Okay, great. So then you can use this to double check in your safety check in the morning that the settings are correct. Fabulous. Fantastic. Thank you.
If they don't show up, then do you put them in?
If you don't see them, please let your clinical manager know so we can get
Okay.
them added for you.
All right, thank you.
But they will still be on the plan of care, the 485,
Yes.
and also in the intervention tab. But if it's missing from this, just let your clinical manager know for that client.
Mhm.
Okay, thank you.
Mhm. Okay, so I'm just gonna close out of this. And then you can press save. Okay, there are no changes made because I already pressed save. I added those in. I'm gonna go here to neuro. We always want to fill out something for neuro.
Allie, I'm sorry to interrupt again. When
That's okay.
you're done for the day with because some patients maybe only check their vents, once during the shift when they're on it. Some it's more frequently. So depending on your patient and the frequency of your ventilator flow sheet readings, at the end of your shift, when you're done documenting all that, you would hit the save and submit button so that form gets sent to us.
Okay.
Okay. All right. Neuro, a lot of times we won't know if they have a headache or dizziness or vision changes, but obviously if they can tell you, put that down. We always want to know if their pupils are equal and reactive. Some people have, their eyes kind of sewn shut. You're not able to do it so easily, but we want to check mark there. And then if you're not able to check it, please make a note. LOC, we want to know if they are at their baseline level of consciousness. You don't have to put a note, but check the box so that we know. If your client has seizure activity and they have a seizure on your shift, you want to fill out a seizure log. Okay, look at, there was a seizure that was yesterday. And so we know, all right, there was a head drop seizure at 10:12. You maybe want to note that there was another, just take a mental note of that, note what time and see if there's a pattern. We've got today's date, time. She had a seizure at, I'm going to say 08:45, and it lasted 1 minute. And the type was, I am going to say, generalized. Is a generalized myoclonic tonic the same as a generalized tonic clonic? I would, let's see if we have a tonic clonic. QRS. Yep, there we go.
Yes.
Tonic clonic. After the seizure, you want to put how the client is. I'm going to say lethargic. Intervention. I'm just gonna, what did we say we were gonna write in here? No rescue meds given. Because our orders say don't give anything until after 3 minutes. So
And-
we're just gonna leave it like that.
And I would address how the patient is afterwards, like were their vital signs stabilized after the seizure? They're safe now. Doesn't have to be a huge note, but just, you know, enough meat and potatoes to let us know how they're doing.
Baseline, resting comfortably. Okay, we're gonna save. Edit successfully. And then we're gonna close. And then the level of consciousness again, they're asking if they're alert and orientated or if they're lethargic. And that's just not just after the seizure, that's, you know, for the whole day.
Okay.
And then if they have a vagal nerve stimulator, that's the wand magnet that you put over their chest. Or agitated, you'd put that. If they have a shunt, everything's pretty self-explanatory here. Pain, I always want either it's present or it's absent. It should never be not applicable. And you get to learn your patient and what their facial expressions are as to where they are in this realm. So if you don't know where your patient's pain is, you would put unknown. Intensity, again, you get to know your patient and you can tell, yeah, it's maybe at a 5. Frequency, you know, that self-explanatory is either frequent or infrequent or occasional, something like that. Endometrial metabolism, this one you would only use if your client has diabetes or they're tracking blood sugar for some reason. So you can put not applicable there. And then musculoskeletal, we always want to feel something out there. If they're non-ambulatory, if they have contracture in both lower extremities, if they're spastic, if they are non-ambulatory, they're always going to have an assistive device as a wheelchair, or if they need, you know, walker, crane. Yeah. And then genital urinary, if they're peeing a lot or not peeing very much. Urinary retention, but we want something urine color. If it's normal, we're good. Voiding, incontinent, if they have a catheter, bowel bladder training, and then note only if it's something outside of their baseline. IVs.
I had a question.
Is that Pamela?
If we cap
Okay.
them, if we cap them like every 4 hours, do we go in and put that in each time with the time that you cap them?
You would
No,
put that.
because No, because you're signing that off in the interventions tab and it's scheduled for every 4 hours.
Okay.
You'll be noting in the output how much output he's getting, so you don't have to sign out that you capped him every time in the urinary section and the intervention, because you're going to note it in your output, which Allie will show.
Okay.
Yep, thank you. But again, you wouldn't have to put your catheters type or size every shift, just once a week, I would say. And then IVs, if they don't have a central line or IV site, not applicable. Equipment.
Yeah,
You're gonna
Alec,
be-
can I stop you one more time? I'm sorry,
Sure.
but I don't know some of your abbreviations. For
Sure.
contractures, RUE means what?
Right upper extremity.
Okay, got it. And so then it's left upper extremity and then it's lower extremities. Okay, thank you.
Yes, and I missaid that, I think, when I said it. I think
That's
I
okay.
marked this as right lower extremity, but
Yeah, okay, thank you.
yep, sure. Equipment, if all the equipment is functioning, you just put a check mark there. No need for a comment. IV, if they don't have one, not applicable. The supervision and conferences, for us, it's always going to be not applicable. This is the same system that our skilled nursing side uses. They use this quite frequently. This is the intake and output. If they are tube fed and the formulas, if let's say the formula is going when you get there, you're going to put the time that you arrived, 8:30. Type is just going to be formula. Route, G-tube. And the total, when this formula ends, you're going to put the total amount that has been given. So let's say they get 500 mils. 500 mil, and then you're going to do a water flush after that, and it's going to be 3 hours later, be 11:30.
Allie
Water.
put before 10:30 because your shift ended at 10:30.
Thank you. There we go, 10:30. Route is going to be G-tube. And total, let's say 30 mils. I always want a unit of measurement, not just 30, but mils, cc. Well, cc's is not okay to use anymore. Ounces, whatever. Output that every 4 hours, this is where you're gonna put that. But 0830, small. If they use briefs, incontinent briefs, all I need is a small void and a large BM. If that's what they have.
Yep. And if you're cathing them, that's where you'd put that total amount for that output if you're cathing. Also in the intake, if your client eats orally, you want to be noting that in there. Say they had 2 slices of pizza for lunch. You're going to say they had 2 pieces of pizza, they ate it orally, and what percentage of their pizza did they eat? Did they eat 25%? Did they eat half of it? Did they eat 3/4 of it? Or did they eat all 100% of it?
Yes. And just use the same system each time. So if they have 2 pieces of pizza or they were given a small, pizza, they ate half of it. And then for total first shift, we want the amount of fluid that they drank or fluid they consumed for their entire shift. So right now we've got 530 mil. If we're cathing and it's 200 mils each time, or if they are brief and it was a small, medium, large, we'll call medium void. Total first shift would be 1 void. And
So
if they had
question,
Mhm.
does the TPN go under intake also? And it,
Yes,
okay,
yes, and you would put, the time that it started, or if it started before you get there, you put the time that you arrive, type TPN. route if it's via the PIC line. And then the total amount that they get.
Okay.
And then if
Okay.
you flush afterwards, let's say 10:30, you do the same. If it's a HEP and then saline, and then route would be PIC. And total would be, 10 mil. So then you would add all of these up and then put total for shift. If you are doing like half or whole or 20%, 30%, just say 8. And then a rough estimate, 40% of all meals. Narrative is your nursing note. Every nursing note should start out with received report from whoever you received it from. If you're a day nurse, it's going to be knock, shift, nurse, client, safe, and stable. And where are they? In bed, sleeping. Okay. And then anything that's out of the ordinary, or just sort of a snapshot of your day. If everything was fine, I would put client if your client goes to school, went to school. And we need to know when and how long that was, from 0800 to 1530. That's how we bill the school for your time. So we need that in there if you go to school with them. Client had a good day. Participated in school activities, blah, blah. At the end of the shift, you want to say report given to mom, who assumed care of a safe, stable client. You always want to state how you found them and how you left them. And then patient tolerated all procedures and medications without problems. Yes. Mary always tells a story of a nurse and a client that she had where nurse luckily put in safe, stable client, left safe, stable client, but then a couple hours later, the client had died. So
Wow.
it was pretty clear that the client was okay when she left, but something must have happened. Care coordination, if you speak to us about your client, if you speak to a doctor or a nurse, if you order medications, if you order supplies, you're going to put that in here. You always want to take credit for your care coordination and what you've done to help your patient. Clinician signature, this is your e-signature for your shift. You want to click that so that it's like signing your name at the end of your shift. Are there any questions? We're done with this one. We're going to save. You want to save.
Sorry, Ellen,
Often.
I was just gonna say that. Make sure you're saving often throughout your charting as you get timed out after 30 minutes. And that's for HIPAA and security reasons. So just make sure, just be a habit. I know the clinical managers do it all the time when we're working and stuff. We're saving more often than we probably need to, just to make sure we don't lose anything.
Mm-hmm. Yeah, maybe do 3-4 boxes and then come up and save. I maybe should have done that. I'm lucky I didn't get timed out, but okay. So this is our pediatric SN visit. This is our head to toe assessment. Interventions. This is going to be what was on your care record, your maintenance record, and what was in your 485. Okay, this is just a list of all of them. Just like with your suction log and your vitals, you have to click on Perform Intervention. This one is for the home program. It is saying that Jack and Mel, or mom and dad, are trained in the care of this client. It's basically acknowledging that they have a backup caregiver, you feel safe reporting off to them, and that everything is good in that sense. So we're going to check that box, and then we're going to put the time that we did it. And I would put at the beginning of your shift rather than at the end of the shift. So, but it's kind of up to you when you put that in there. This is a standard order or standing order for body system. Everything that starts out with standard orders for body system and every shift have to be check marked every shift that you work. So we're going to click that. We're going to go through this. Look, it says vital signs, including temperature, twice per shift. It should be done, if at all possible, at the beginning of your shift. Some people come on and their client is asleep and you are not going to wake them up to do that. That's fine, but you can go in, and if your client is on an oximeter, look at the oximeter. We as nurses, we know what our clients sound like when they are well. They're breathing. You can look at their skin color. You can see how they're breathing. Is it equal? There's a lot of things that we do, maybe without even thinking of it, that can let us know that they're okay for them. You can do a respiratory rate at that time also, and that should be done within the first half hour of your shift. So that's 8:55. You have to put in a time or it's gonna not check that you did it. That check mark will be gone, and then I'll have to send it back to you for correction. Every shift, monitor and document cardiac status. Oh yeah, we do that within the first half hour of the shift. Developmental, standard orders. Client is provided age-appropriate activities and toys. If they're asleep, that's age-appropriate. They're supposed to be asleep. Everybody is at a certain time. So we're
But
gonna
you're still gonna sign off on that, because same with every shift one when you're providing age appropriate stimulation, because if your patient wakes up, you're going to talk with them, you're interacting with them, so you're doing that. So
Mhm.
a lot of night nurses miss some of these. Make sure you're just signing off, because you do that when you're working with your patient. If you're repositioning them, you're not just turning them and not saying something. You're interacting with them. So take credit for that.
Exactly. If you did not do something, let's say you were not able to, you would check it, and then you would put a time and say unable to do because of, due to, whatever. Okay, and then we're going to save. Save, and then we're going to close. We never want to copy from a previous visit. That's, I don't think it even is doable. Medications. Everybody's shaking their head no. Medications, administer medications. Everything in red is things that are due, during your shift, or due next during your shift. So atropine, it's scheduled for 8:30. I am the clinician, and let's say I didn't get to it until 09:10. Okay. We don't have to put site, but I'm going to put client asleep. And so we waited until that client was awake to do their eye drops. Or their, that's not, yeah, well, it is an eye drop, but we're using it buccally, I think, yeah. Things like, now this is what's important is I had a nurse that came in at 7:04. She had medications that were due at 7 and she put in 7 o'clock for all of her meds. And so it
Oh.
kicked her out. So you want to make sure you're putting in, well, putting in between the times that you are
There.
there. Just gonna do this.
What
Okay,
are the,
thank you.
what are the little boxes over on the left-hand side? There's a check mark, looks like blue, and then something blue and red.
Paste. Yeah, I don't know exactly what.
Maybe the red means something else, also do your shift, because then there's a, you follow over to the right and it says
Oh.
just do it 8:30.
Okay, yeah, I don't.
You don't need to worry about those little blue boxes. Looks like it's a copy and paste option. You only need to worry about the little box on top of those, right next to the name of the medication, because you have to check it to administer it.
Mhm.
Okay.
If you check a box next to the med and you forget to put a time into it and you go to save it, you will lose it. Nothing will
Mhm.
save. So
You will lose it. It won't tell you you need a time. You'll just lose it.
you'll lose
Mhm.
everything that you tried to do.
Wonderful.
So just keep that in mind if you check a
Good to
box
know.
to make sure you put a time in. It
Okay.
only has to happen once for it to not happen again to you.
Yes, I'm gonna press save here just to be sure. And then you won't be able to clock out either. You'll have to go back and redo everything. That's it. For PRN, let's say they needed a PRN albuterol. We gave that at 08:45. And that was due to wheezing. Right? And then we're gonna go down here.
And if you
All right.
give an as needed medication, you need to put a note in the comment, because the comment replaces the PRN medication response form we used to have. So you'll put the reason why you gave that PRN, and then when you do your follow-up a half hour later, depending on the med you gave, you can update your comment to say whether it was effective or not. And Allie will show you that once she
Yes.
saves and exits out of the SMAR.
So then
Nope, Allie, will you just hit save quick?
I did.
And then exit out of the MAR and show them how they'd go back in if they went in like an hour later.
Sure. Okay, so then let's say we're doing more, suctioning more. We'll go to medications. It's been an hour. We'll go down here. You see it's due to wheezing.
Yep.
Administer medications. We're gonna go down to that note. We'll say 09:15 effective. Save.
We will send charts back for correction if you're missing comments and responses to as needed medications, because we do need it for documentation purposes.
Yeah, that's an MDH thing. That's a board of nursing thing. Okay, so forms. This is, a lot of us have clients that are on controlled medications, and this is going to replace, there's lots of stuff on here, but most people are going to be using it for the controlled substance log. You click on, I'm going to explain that better. You go to forms, you click on add new form, and then you're going to scroll down to controlled substance. And it's going to populate every single drug that they are on. So you're going to need to know what is controlled substance and what is not. We're going to, all the diazepams. Now you're going to say, why are there 3 of the same thing? This client has 3 different doses of this medication, but they are all taken from the same bottle. So it is, or all oral solutions of control meds are weighed. If you do not have a scale in your home, a food scale in your home, contact your clinical manager and we'll send one out. We're going to click all 3 of them and we're going to put the same thing in each one, right? So we came on shift. There was, when we came on shift, there was 100 grams or ounces or whatever. I can't just have 100 and nothing. I need a unit of measurement. The amount of med added to supply, if no one gave us anything, I'm gonna get rid of you, you're annoying. If there was nothing from the pharmacy added to the med, we're gonna put 0. We always have to have something there. Amount given, we're gonna say, let's say they had 5 ml. 5 ml at this time. Amount wasted, none. Amount of med at the end, we're gonna put 95. But you're gonna have to weigh it because we don't know how, I don't know how much 10 mils weighs, but you're gonna weigh it and put that there. Again, we're
And to,
gonna, can
and
you
to
get rid
save
of
this form, all boxes, all those 5 boxes need to have something in there to be able to save it. It will not let you save it. So if you're starting this at the beginning of your shift, you'll still have to put a total for amount of med at the end of your shift, and you would just update it at the end of your shift if it needed to change. But it will
Yes.
not let you save the form unless you fill out every box.
Yes. Now, Becky, this is something I just thought of. Let's say this is a 5 ml dose, this is a 10 ml dose, and this is a 2.5 ml dose. But they're all coming from the same bottle. How do we do that?
The end weight is going to, at the end of the shift is when they're weighing it. So the end of the shift, it's going to weigh differently.
It is,
So-
but what do they put for amount given?
The amount that they gave for that dose.
Yeah, I have someone that has Adderall listed. It's the same amount in milligrams, but one dose is 5 milligrams, one is a 2.5. So there's 2 Adderalls listed, both 5 milligrams, and they put on the one, it's a full tab they give, on the other, it's the half a tab, and then the total matches the bottle. So the bottle has the same amount at the end, it's just noting the 2 different doses. So that would be no different than these liquid ones having different
Okay.
dosages, but the weight at the end will be the same.
Right,
Okay.
because you don't have to put in each time you've given the dose. That's in your med log. All you need to do is the totals, correct?
You want to put in the amount that you gave here also.
Right, but you don't have to do that each time. This is only
No.
per day, right?
Yes.
Yep.
Yep. That's correct. There we go.
So because it has 3 different doses of the Valium, you have to fill in all those boxes and put in zeros.
Yes.
Okay.
Yep. Each one needs to be filled out, unfortunately. For
So
that.
if ours is like 2 to 10 milligrams, are we gonna have like 8 boxes?
I
I don't know what yours looks like, Karen, because I haven't got him all the way set up yet.
Okay.
So you'll find out when you get back from your LOA.
Yes. Okay, so we're gonna just save this. And then we're gonna close. Okay, so let's say now it is at the end of my shift. I'm gonna go back to my pediatric SN visit. And I am going to submit my charting. Right now it is 9:25. 9:25, and we'll just see what comes up here. Gonna submit that. All righty. Vitals outside normal range. Let's see. BP diastolic, I put 80 and it's supposed to be 75. Was the physician notified? No, because sometimes it does get up that high. Notified to staff. Yep, I'm gonna say, you know what, he threw an 80 diastolic on me. Let's check the next couple few on here and see if he's okay. Or you just put baseline for client. Or he was crying.
If this warning box pops up for vitals outside normal range, you do have to check whether the doctor was notified or not. You should be notifying other staff in the home if vital signs are off by noting in the communication book. In addition, you must put a note in for the CM to see why the vital signs would be outside of the normal parameters.
Yes, if they're out, if the client was crying during your measurement, you're going to put client crying, but you're going to want to recheck every 15 to 30 minutes after you get the outside reading, or you want to give them a few minutes to calm down after they've cried, recheck it, and then if it was at baseline, you want to note it here, but then you also want to note it in your vital sign readings. Continue. Or if they have orders, if diastolic blood pressure goes up 80 or above, give, this medication, and you say this medication was given and it was helpful. All right, now it's going to say chart was submitted with warnings. I did our checkout, that's fine. When your CM goes in to check on it, they're going to check that and make sure that everything was followed up on and that it's all good.
So Allie,
And you're done.
Can you close out of there so we can show them what the difference in the little color blocks looks like?
Yes. Okay. So the legend for the color boxes is down here. If you remember when I first signed on, there was a notation in the chart that I had something outside of range, or that something that needed to be corrected. So we're going to go back here, and I'm going to click on this. It says, please sign off on all standard orders for body systems and every shift in interventions tab. Okay, so we're going to open chart. All right, and there it is again. We're going to go into interventions.
And just for you guys at the field staff, you will have to put a note in while you're editing the chart. It doesn't show up for Allie because she's a clinical manager. But there will be, you will have to put a note. So if your chart was sent back for corrections to sign off on some standard interventions, just put fixing interventions.
Oh, yeah,
But you will have to note why.
Will you note that next to each intervention that you fixed?
Nope, it's just a one time when you first open the chart to make a correction.
Okay.
Here it says every 4 hours on PRN to disinfect reusable suction devices. You don't have to put it in there every 4 hours. You just put it in. We started it at 10. That was my first time. And then we're going to go on our merry way. Third orders for body systems. Yep. And you do want to read through these and make sure that you are actually doing that. I'm not doing that right now.
Hey, Allie.
Uh-huh.
Sorry to interrupt.
No.
If you do something more than once, you can click that little plus sign on the right, and that'll give you your next. Okay, so there you go. Click that. So then you can put the next time that you did it.
You always want to use military time. If I were to put if I were just to put 2 o'clock, it's going to say 2 a.m. and you're going to get an error as you're trying to clock out, and you're going to be sitting there going back and fixing it. And so there we go. 4 times per day. Are we saying that they need to go in 4 times per day and do this, or if because it says 4 times a day, they're signing off that they did it, and is that good?
I'm not making them on nutrition because they're already noting that in the intake and output. So there's no need to sign off nutrition stuff like that 4 times because they're already putting those totals in the intake on their head to toe assessment. So if you're putting your totals and notes like BMs and all that stuff in your head to toe, don't put those same comments in the intervention tab because that's just double documenting. If you put it in your head to toe assessment, you do not have to put that same comment in this intervention. And for interventions, you can sign out multiple times on them if you would like, but if you're already doing that in your head to toe, you only need to sign it off once for your shift.
Okay, so maybe this every 4 hours to disinfect reusable suction devices, they should put in every 4 hours
They
for their
can.
shift.
They
Okay.
can. I'm not making my staff go back in and
Okay.
change things
I'm
like
not
that right
either.
now. If you want to document every time you do it, that's fine. But to me, if you're documenting it, you're acknowledging you're doing this every 4 hours.
Mm-hmm.
Something like oral cares that you're doing twice a day. Would you put those times in?
I personally don't have my staff do it because again, they're not acknowledging that they're doing it twice per day.
Well, and you're already documenting that in your elsewhere in your flow sheet. It strikes me that it's redundant.
Yeah, I'm not
Yeah.
making staff go in and I have one staff who will go in and do an intervention every time they suction, even though they do a suction log. And I've told them they don't have to and they continue. So you're not going to get in trouble if you do it.
Right.
But I'm not going to enforce it because you're already noting it elsewhere.
Right. You're double documenting.
Yep. And double documenting is kind of a sketchy area. You can do it, but you have to make absolutely sure that there is not one iota difference between
Right.
any of them.
Correct.
You can't have one be 10 o'clock and another one be 10:01 or 10:05. If you're going to be double documenting, everything has to be the same. Okay. All right, so we're going to save this. Did it say save successfully? Save and close. There we go. And then you go back to pediatric SN visit. Here, we're going to submit it again to QA. We're going to leave everything here the same. And then you're done. You don't approve your shift. You don't send for correction. You don't close.
Yours
You
actually
can
won't.
close.
Yours will only have the option to close once you've sent it. Allie's the
Okay.
clinical manager, so she has those other buttons, but you won't see that in yours.
Okay, so does anybody have any questions at all? Any other questions? Anything you want me to go through
Yes.
again?
Allie, can you do a change order in the medications tab, please?
Yes, thank you. Okay, so this was yesterday's. I'm going to X out of here. I'm going to say completed. Close. And it goes away. Go back to my schedules. No, that's a white schedule. Now where do I?
Go back to your top tab of your internet. It'll bring you up to Rivers.
Okay, there we go. I go back to my eChart. Okay, so let's say an order came in, kid's sick, gets on an antibiotic. You're going to go to medications. and you are going to go to this medication.
You've already submitted it, Ally, so it's not going to let you do a change order.
Okay. Dang. Can I unsubmit it?
Go back to the pediatric SN visit. And I think if you send it for correction,
Ha, thank you. Okay, so you're gonna click on medications. And then we're gonna click on this medication. Instead of administer medications, we're gonna go on to medication. Everything's gonna be a medication change order. Even though technically it's a new order, it's gonna be a medication change order. We wanna make sure, double check the physician. Make sure that it is, let's say, Dr. Kavanaugh. We had a respiratory infection and he prescribed an antibiotic. We want physician order, not verbal order. Medication, and it was ordered today. You don't need a time. The staff is me.
Allie, I'm going to just pause you for 1 sec. You can check physician verbal order if you are actually taking the verbal.
Oh, yes.
If you're getting it off of eChart or the prescription label or that's where you could put the physician order. So if you do take the actual telephone physician's verbal order, then you can check verbal order. It is okay to check that.
That's right. And the order prescription will say amoxicillin.
Nope, Allie, they don't have to type that out. Scroll
They
down a
don't?
little. Nope. You can either add new medication if it's a new medication, or you can edit medication. So if you have to add a new med or DC a med, if you're going to change a med, you can go into the edit medication. If it's just adding a brand new med, you'd go to add new medication.
Should we go into edit medication?
Yep.
Let's say, yeah, gabapentin. That changes a lot. Right now, they want 19 mils. Let's say we're going to change it to, 18 mils. And we would do the math conversion. 250 per 5. We've got 5 milligram per mil. 5 times 18. Anyone? 90. So it'll be 900. 900 milligram per 18 mil. And we're gonna go, it's days, that these are the times that are given. Yep. And then we're gonna save. Okay, the current order was DC'd. We'll say it was DC'd yesterday. DC time, we'll say 10 o'clock. Was the last dose of that medication that was given. Well, actually, it was given at, we'll say 1930.
Allie, it's going to have to be after you last performed it because you just performed it this morning at 8:35. So you can do
Okay.
today's date, but do like this evening instead.
No, I would do before 2:30 because he has afternoon dose.
Okay.
So you have to pay attention to the times you're administering meds. You can't change. You can't DC a med if you've already administered it. So Allie gave the med at 8:30, so she has to switch this time to be between that next dose. So it will update your MAR appropriately.
Okay, so then it would do today, and we'll start time at like 1400, just so that we can get it in before that 2:30 time. Proceed. Then you get that green light with a green check. That's always a happy day. And we'll close.
And
then
then
this
see it
is what's
typed in that whole order for you, so you didn't have to freehand type it.
Yep. Now let's say they have an antibiotic too that you have to add. Do we want to put new medication to this one?
Yeah, if it's a brand new med, you would.
Okay, and so amoxicillin. 250 per 5. Getting 500 milligrams. We always want the strength first. Without fail. You don't have to put in the mils, but if you want to, you can do mils as long as you have the strength first. Route is GT frequency twice daily for 7 days. And you have to use one of these. Let's say they didn't have the 7 days on there. Twice daily. Go down here to comments, print comments on POC for 7 days. This is a planned day's time. We're going to give it at 0800, comma, 2000.
You have to put times in for you to be able to administer it on the MAR. Otherwise, it won't let you administer. So make sure you're putting in those times.
Allie,
Save.
with this one too being a short duration, you should put in a discharge or a discontinue date too, and then it'll automatically
Yes,
off your MAR.
that's right. I forgot to do that. Thank you, Shar. Okay, I'm going to cancel this right now because that's just saying that an antibiotic, that there's an infection control form that needs to be filled out, which is absolutely correct. And I will do that. 7 days from today is the 24th. So the DC date is going to be 11/24. There we go. That's 7 days. Save. All right, and we want to do we want to fill up infection control form now? Yes, we do. Okay. Okay, it's not giving me a control form. That's fine. I'm going to go to my Forms tab. I'm going to add new form. Down to infection control. Onset date. Antibiotic, let's say he started to feel kind of icky on the 14th. We are going to put in here that he was respiratory. And admit is you choose this option for suspected sites of infection as identified during patient admit. He was admitted to accurate home care during the time of his infection. So we're going to say admit.
Sorry, Allie, I'm going to correct you on there quick. So
Thank you.
Admit is only if they had that when we admitted them as a patient. So if they came to accurate and, with a diagnosis of cellulitis, then that would be something that we would check if their infection continued to go. If it's something that they acquire while they are with accurate. So if they were already a patient of ours and ended up with, a UTI, that would be, and they did not have that when they came to us as a patient, then it would be, urinary acquired while they were under our care, if that makes sense.
Okay, yes, that does. Thank you.
Yep.
And can I ask about add diagnosis? Is that a drop-down box so it can give you many, many different ICD codes?
No, it is not.
Okay. So
So
that's something that you have to put in yourself as far as the diagnosis.
I would say because the clinical managers will go in and review this as well. The clinical managers can update the diagnosis. You just need to start the infection form.
Okay, so you don't necessarily need to put anything in the diagnosis, or you can put in respiratory infection.
you wouldn't put that, that wouldn't be part of a diagnosis that we would add. If a client has a new diagnosis of, let's say, Lennox-Gastaut syndrome that for seizures, that would be something we'd fill a change order for. Get the ICD-10 code and then
Basically, for
send that
field
to the
staff,
doctor.
you don't have to address the diagnosis section in this.
That's what I
box.
needed to know. Okay,
Okay.
thank you.
Yes.
Because you're going to put respiratory illness a little further down.
Okay,
Mhm.
thank you.
Yep. We have increased sputum production. Pathogens identified. We don't know. They're not going to necessarily, physician order was the amoxicillin. 500 milligrams twice daily for 7 days. Treatment, yellow zone. So call. Resolution, client seems to be improving. MD notified, yep. It was Dr. Kavanaugh. I don't know if that's how he spells his name, but that's how he does it right now. And then we're going to go up here. We are going to save and submit. We're about to submit the form. Yep, we want to continue. And then do they approve it or do we
No.
approve it?
We
Okay.
No, we don't. We go in and update it to whatever we need to, and then the QAPI people, whoever manages the infection stuff, goes in and reviews and approves the forms.
Okay, great. All right. I'll close out. And then you will see here that when you go to medications, it will have the if we
You might
refresh
have
our
to
screen.
refresh the screen.
Uh,
Just hit display. There it was.
There
Right
we
at the
go.
bottom.
Okay. In alphabetical order, just like how it's so helpful. There you go. And then you can administer that on your MAR then. Okay. Is there anything else?
Once you've made your changes like Allie showed before when she went in and updated the interventions, just when you're making chart corrections, you're just going to be resubmitting to QA to get that resent to us for review.
This is Chris Erickson, and this seems like a probably foolish question, but I'm going to ask it anyway. I'm
Good for
assuming
you.
I'm assuming the iPads are going to come with a keyboard so that
Yes.
we can type.
Yes.
Mine did not.
Okay,
What?
so I'm assuming
Mine-
somebody in authority is going to say yes to that.
Yes, all the iPads should have a keyboard.
I'm
So
going to tell you right now, Chris, I have your iPad and it does indeed have a keyboard.
Yeah, I mean, I had the one I was given yesterday had no keyboard.
Shar,
Okay.
you're saying does or does not?
It does. They have keyboard cases.
Mm-hmm.
So it kind of acts as your keyboard and protects the iPad.
I
Yeah.
wonder if you
So-
were given the wrong iPad, Pamela, because
Thank
I've
you.
used the iPad in the home that you are in and there's a keyboard.
Perhaps the person before took the keyboard off.
It's possible because they were still logged in.
Oh, then it wasn't the wrong one.
I would follow up after this meeting on that.
Okay.
I have another
right.
question that may be silly, but I'm going to ask it anyway. The client that I'm taking is very, very labor intensive. And so the chances of getting all of this charting in before the end of the shift may be difficult. Is it possible to access this information when I'm at home so I can complete my charting?
No, you will not be able to do that at home. It's going to be it's going to take a while for you to get used to it. But what we're hearing from people is that as you use it and as you get used to it, it gets much quicker.
Okay.
It's going to be clicking boxes and putting in times
Okay.
mostly. Yes.
Okay.
Was the iPad in the case and was
No.
It wasn't in the case.
No, she
Allie,
handed me a.
Sorry, I'm going to interrupt. I think that conversation could be not held during this meeting.
Okay, sorry. Thank you.
Nope, that's okay. All your questions are great. I'm glad you brought it up, but that could
Mhm.
just be further followed up with Allie after this call.
Okay, great.
Just
Thank
to
you.
keep confidentiality between your client and stuff like that.
Okay.
This could
If
have
you
already,
Oh, sorry. Who was talking?
Karen, this could have already been covered, but under, and I know I'll need more training, but under the interventions, are we to do every intervention, every shift we're there? Because that takes the place of the care and the maintenance records? But
So
because to
yes,
me, it kind of looks like a 485.
it is,
Yes.
but you're going to sign off. So you always are signing off on that scroll back up, Allie, please. That area home program, you're always signing that one off, no matter what.
The area
you
home
go down-
program.
Yep, area home program.
Okay.
When you go into area cardiovascular, it says the very first one is standing orders for body system. That is all the interventions that you do regularly as a nurse that you don't think about. So we put them, instead of having you sign off individually, it's all one big block of intervention for you for each body system. So that needs to be signed off.
Because I know, because we went to the box, the body system, the CV, and put in the regular heartbeat or the whatever, so.
Mm-hmm.
Then the ones
Okay.
that say every shift, those need to be signed off. If you have ones that say like twice a day or once a month or once a week and it's not something you do on your shift, you don't sign it off.
Mm-hmm.
But you do need to sign off every shift.
You mentioned that before.
You do need to sign off every shift and standard orders for body system. So
Mhm.
you will see the whole entire care plan in here, but you're only signing off on what's appropriate for your shift. And if you are finding any discrepancies for what is done on your shift, please reach out to your clinical manager.
Okay,
Mm-hmm.
thanks.
Good questions.
Yeah, that was a good question.
Does anyone else have any other questions?
Sure, let's stay with paperwork.
Yeah.
That
Yeah.
was a comment.
Yeah.
No, and you will be able to reach out to your clinical manager for more support. This isn't the end all be all for your training on this, and we understand you'll probably have more questions. And as they come up, please reach out to us.
I suppose there'll be a lot of them sent back for correction. And then we'll just learn.
Mm-hmm.
Yep.
We're all working really hard with all of our staff, especially when they first start on this. So we are, trying to be as supportive as we can, really walking you through changes if you need to make corrections, that type of stuff. So we're not just saying, here you go and do it. We're not doing it for you, but we are helping you and working with you. I haven't really heard any negative comments from anyone that I've had to speak with. And I mean, I've helped people while I'm on call. I've helped people when other CMs weren't available. So we're all working as a team to make sure our staff are comfortable. And if you are finding issues with getting your charting done during your shift, it is, like Allie said, it's going to take you a while at first and you will be slow at it. I'm not going to lie. I was slow when I first started training. The more you do it, the easier it becomes. That's what I've heard from my staff. And if you have issues, just reach out to your clinical manager because we're here to support you.
Are we going to have a like hands-on training also? Instead of just this?
Karen, we could get you scheduled for a training because you're out on a LOA right now and will be when I set you guys up in your home. So when you come back to work, we'll follow up with you then on that.
Okay.
But the home will already be live, so I will not be going out and doing hands-on training, but I will get you trained with someone.
Okay.
Allie, I have a question.
Yes.
Do you guys have like a IT or technical support like during the nights and stuff?
No, we don't have IT support, and they would just be for if there's problems with the iPad itself. We've only had one issue where we've needed the IT support person to intervene. Otherwise, mostly it's us. Uh, it if it is after hours, your clinical manager can help you between 8 and 5 during the day. If it's after hours of the weekends, please call on call. Every clinical manager should be able to help you. If there were something to happen with the iPad, let's say it locked you out,
Yeah.
you are able to use paper for a short time in an extreme situation. And you'd want to let your clinical manager know and the on-call people know that get the okay to use paper for that time.
So will we have a backup chart in the home with
Yes.
everything that you need?
Mhm.
And then I just want to add that if you have issues logging in or with your credentials or anything like that, your staffing coordinator is able to help you with some of that as well. We obviously don't want the staffing coordinators to jump in when it has anything to do. Once you are in that eChart, that is a clinical manager thing, because the staffers are not nurses, so we don't want them helping troubleshoot with any specific nursing questions. So we kind of divide that. But if you need, they can help troubleshoot if you can't get into the iPad. They know where to look and how to do that. Or if you are unable to log into Kantime or need a password reset, things like that, they can help troubleshoot some of that, and they'll escalate it if it's something that they're unable to. So they can also be a resource.
Yes, clinical managers are not able to change passwords. We don't know how. That would be a staffer. All righty. Is there anything else that you'd like addressed?
This was very helpful instead of just going through a paper copy to actually go on and see you click things. So I appreciate
Okay.
that. Thank you.
Yeah, no problem. Sure. I'm glad we were able to get this set up. Yeah. All right. Well, thank you all. And we will, don't hesitate to reach out, and we will see you all later. Thank you so much.
Thank
Thank you
Ally.
everyone for joining.
Thank you. Yeah.
Bye.
Bye-bye.
All right, there's 3 of us left. I was hoping a couple people would stay on.
I am still here.
Huh?